The rationale for treatment we all know, but in fact many pulps become stressed and eventuate in disease. If the decision is endodontics, then what we'd like to do is make complete access. We'd like to secure canals to their terminus, and once we have a secured canal, we shape these canals. Shaping facilitates cleaning, but it's important to know that shaping also facilitates filling root canal systems. We've often talked about the thrill of the fill, but it can only happen if we removed all the pulp and its contents from the root canal system. Well, to look at the rationale just a little bit more, we need to appreciate that heavily restored teeth frequently break down, and the disease flow is from coronal to apical. It must be appreciated that these lesions are not germane to the bone, they do not arise from the bone, but they arise secondary to breakdown. So any communication from the root canal space to the external surface of the bone should be considered a portal of exit, and the lesions then form symmetrical around the portals of exit. So we need to look at our radiographs cleanly and look periradically so we can find more of these endodontic problems as they initiate. Well, the goal that we'll be speaking about a lot will be getting the access, negotiating these canals to their terminus, and shaping. We need deep shape so that we can exchange our irrigants. It must be fully understood and completely appreciated that active irrigation can allow our irrigants to penetrate, circulate, and digest tissue in the uninstrumentable portions of the root canal system. And of course, it's quite easy to fill a well-shaped canal. And of course, warm gutta percha would be on my mind. And if we can get these canals filled properly and eliminate the root canal system as a source of irritation, then there's enormous capacity for regeneration. So, properly performed, endodontics is the cornerstone of restorative and reconstructive dentistry. Well, healing needs to be looked at over the months that transpire and over the years to keep following our work to make sure that all is well. That's one way we measure our success. Well, I'd like to talk to you then a little bit about how what we just spoke about influences everyday cases. We've all seen cases that come in, and in some instances they're failing. And when they're failing, we need to look back about those goals we just spoke about. Notice the lesion of endodontic origin on the mesial aspect of the anterior abutment. And there's a silver point. This is a classic example of an overextended case vertically, but it's internally underfilled. So the prescription is to make a careful access, remove the silver point, reshape the canal and clean it, and let our irrigants work out into the uninstrumentable portions. And then if we've taken materials out, then we can move filling materials in. Of course, this post-op film is kind of exciting, but it becomes more important as we follow this case and look at the 15-year recall. And notice the capacity for bone to regenerate when we've done the endodontics. See, endodontics needs to parallel the extraction because what the extraction serves to accomplish is it removes the pulp 100% of the time.